So what's new for 2026? End of 100 level course, right? What's new for 2026, and how can you be successful with these programs in 2026? The biggest change is a code expansion for RPM. So for the history of RPM, there has been the code that was originally chosen, and it really was maybe not arbitrary, but it was chosen as a balancing act. As well, how many measurements should I have to take as a patient before my provider can bill for RPM, for the device code of RPM? And the ACA, and it kind of came down to, well, we'll do 16 measurement days. So out of a 30-day period, you have to have at least 16 days where you took at least one measurement to bill in the old regime. And that was, trying to keep us to that, you didn't have like de minimis monitoring debillable. The problem with that is 16 is very high. For some conditions, it's not that high. For other conditions, it's way more than is clinically needed. So since the beginning of RPM in 2019, basically, there was a push to expand that out and not have that many measurements be required. So this year, as of January 1st of this year, we finally have a code that allows you to bill for under 16 measurement days, and now you can bill for 2 measurement days. So this doesn't mean that every single patient should only be taking 2 measurements, but what it means is that patients who take just 2 measurements can be billable under this new code. This new code pays the exact same amount as the 16 plus measurement day code. So it basically is a full expansion of the code set into new patients. With our customers, we have found, so it changes, right? It's give or take. It depends if it's a cardiology group or internal medicine, but generally, rule of thumb, what we've seen is without any change in patient education, anything like that, this is increasing the amount of patients who hit the criteria to bill each month about 14 to 15%. So not bupkis. And as you start rolling out new types of modalities of monitoring, this definitely increases it even more. So significant. The other new code, which is I'd say less significant but still significant, is the time code. So RPM has historically required 20 minutes of management time. So the way RPM works is you have the device code. Device code is running as far as how many device measurements have been taken each 30-day period. A lot of people round it to a month and just do it monthly. And then you had the time code. How much time was spent by clinical staff managing the RPM? So it used to be 20 minutes. New code is now 10 minutes. So it pays half the amount of the 20-minute code, 20-plus minute code. That said, you no longer have to spend a full 20 minutes. And this is especially important for like folks who've been in RPM for a long time, and there's still value in it, but you don't need to spend 20 full minutes every single month with that patient, right? Talking to them and doing management of the patient. So this lets you have a lower touch program and still get a reimbursement for a 10-minute amount. Zooming out, the billing for 2026 looks something like this. And we have a graph and a chart. First, the chart. So, and this is the national average. Depending on your geography, the amounts will go up or down, generally up from these, but give you an idea. Initially, when you first enroll a patient in RPM, after their first 2 days of measurements, you get a setup and training code. It's about $22. That is a one-time code. Then every 30-day period or month, most people round it to a month, but every 30-day period, you get 2 or more measurements on a patient, you have a $47 monthly recurring reimbursement. And then you get paid now in sort of a sliding scale depending on how much time that you spend with the patient. First 10 minutes, you get $26. When you hit 20 minutes, that goes up to $52. And then for every 20-minute increment after that, you get another $41. So it looks something like this. Enrollment, wonderful. Helps satisfy some of the cost of the device and getting the patient up and running. And then every month from that point forward, you're getting the base RPM rate for 2 or more measurements, which now is the majority of patients, right, are getting that, versus it used to be 85, 90%. Now it's much higher than that. And then you get a 10-minute if you do the additional 10, or every 20-minute increment from there, it goes up to a total of, if you do 60 minutes of care management on top of the RPM device, you get about 181 bucks. To look at the change between 2025 and 2026, it is significant. You get a certain amount of patients that are between 2 and 15 readings, just because patients, aren't taking their measurements. Sometimes they're on vacation, sometimes they forget. 2 measurements is, I think, arguably it's too low, but the idea is it gives the doctor a lot of flexibility. CMS has been pretty clear that they expect most patients to get more than 2 measurements, but they're making it low specifically because they're trusting the provider, the physician, or whoever is overseeing the program, to make sure that it's still a valuable amount of measurements that most patients are getting. So don't go out to every single hypertension patient and say only take 2 readings, but if they get 4 or 5, or you do it twice a week, or whatever it might be, it gives you a ton of flexibility depending on the conditions that you're monitoring and things like that, to allow for program flexibility and still get that reimbursement. We're seeing an average revenue increase of about 18 to 20% for the expansions, given patients that you don't quite hit 20 minutes with, and patients that you hit that wouldn't have hit those 16 measurements otherwise. So on top of that, and kind of also included in that, there's been some policy, maybe not changes, announcements as far as these sort of programs. So one, the bottom here, these policies with the physician fee schedule and new billing, they're a pretty big sort of, full-throated support being thrown behind RPM CCM in these programs, which is good. On top of that, we now have a new value-based programs and they're pilots. That said, they're 10-year pilots. They're kind of announcements of. So the biggest one is the access program. So the Trump administration came out and announced this as sort of, they had Dr. Oz, and they sort of did a whole song and dance about it, because really, I mean, it is innovative, but you could tell that it is not just sort of usually these Medicare improvement sort of programs, innovation programs, are like these like slightly archaic sort of built things in the background, where they're released, and all of us wonks in the industry talk about them and are excited about them, but they're not like press releases to the general public. This was at least an attempt at the opposite. They tried to really go out with bells on for this, and really explain how it's, and position it as a major part of sort of the current regime's views on how they're going to attack the chronic condition crisis and improve health for the U.S. So I won't go deep into this. This is something that we've done a lot of writings on, and I'm sure we'll share in sort of the end email after this, sort of more on it. But far be it to say, they are basically having a secondary value-based care payment version of RPM that is allowing for outcome-based payment, or at least half of the payment is based on outcomes for different conditions, one of which is basically blood pressure and how much you've been reducing blood pressure for patients. You are not able to do both access and fee-for-service. They have not announced how much access is going to pay, which makes it hard to apply, given that the applications are open. That said, it is very interesting that they are making this such a big part of their positioning in general. So something to at least we take away from that the current administration and the previous one, and CMS in general, are all in on remote care and technology-enabled care, particularly of chronic conditions. There's going to be more tying it to sort of outcomes. That said, the underlying fee-for-service model is also not going anywhere. And if you are flexible enough with these programs, you can participate in both, participate in one, but at the very least know that there's tons of underlying evidence just in the announcements and the different programs that they're trying to run, that remote care is becoming more and more a standard sort of care, right? It's a core aspect of care that CMS and really the other payers too, but CMS particularly is incorporating into what their plans are for the future. That said, as much as CMS is saying, rah RPM, we're going to expand things, they're also looking at it and seeing how much the reimbursements are being paid out and saying to themselves, well, these programs are pretty broad and we need to make sure that folks are doing them correctly. Really, the OIG has been the most sort of boisterous on this, saying, hey, great when done right, but also hard to police to some extent, right? Because there's no in-person visit. Some of the time that you spend might not even be direct talking to the patient. So there's a compliance and oversight, not a problem, but just it is not as easy to sort of supervise and police these programs as in-person visits, right? Where you call the patient and you say, hey, were you there at this time? The patient goes, yeah. And it's okie dokie, sort of onward march, right? Here, maybe you were doing reviews of the measurements, and that's in the record, but the patient doesn't know that, and it's just harder, as you could probably imagine. I won't go too further into it. Harder to please. On top of that, during COVID, lots of fly-by-night vendors and lots of folks not fully understanding how to do the codes, but sort of acting in good faith and billing for 2 measurements and billing for notifications when they weren't measurements. Bad faith programs, or just folks not really understanding and sort of not caring to understand. So because of that, as well as sort of the push on the one side to expand these programs and pay folks more for them and try to get them out there more, there's an onus on everyone's part to make sure that you're keeping your nose clean and you're dotting your I's and you're crossing your T's. And that's not hard to do, but you also can't be like belligerent and flip it and not do it. So there are more audits happening, albeit not as many as I think most folks expected, because there's all still expansion in these. But you don't want the eye of the OIG or CMS to sort of fall on you. So just make sure that when you're doing this, you are having good documentation, and we'll talk more about that throughout.